Okay, hello everyone. Thanks so much for being here. It's no secret that this is such an important topic. We'll get more into that, but I really appreciate that you're taking the time to serve your community, to serve your patients in this way. So a few disclaimers and then what I hope that you're getting from today, what we hope you're taking away. First is to really understand the research is robust, get an appreciation. We're going to get the tip of the iceberg here in this talk today. This is really a big picture overview of these topics and take it as such. There's, if you like to nerd out on the research, you can go into PubMed after. Really learning how to teach your patients, your clients in plain language, how inflammation in the body can be affecting their mood, be able to identify sources of inflammation. We'll be looking specifically at certain sources like stress, microbiome, and such. And then really what I want you to be able to take from this time, I know your time is so valuable, is that you can take something into the office on Monday. Maybe give it the weekend to think about it, but that you maybe already have someone in mind who you're working with, either in your practice or even your life, that could really benefit from this information. So even if there's one thing you take, that's what I'm hoping for today. So we're covering specifically what is treatment-resistant depression, what is neuroinflammation, and then really be able to have tools to assess for neuroinflammation in practice. And then, like I said, have tools right away to treat. So when we use the word depression, sometimes it doesn't necessarily have a definition. We use it in everyday language, but here we're talking specifically about major depressive disorder, different than everyday mood, different than grief, which is a really very valid human experiences. But in this case, this is depressed mood or loss of interest lasting for more than 2 weeks. It's one of the most common mental health disorders and one of the leading causes of disability in the US and globally. And so if we look at the definition, this is the diagnostic tool. This is from the DSM. We see here, I just want to highlight that I emphasize it here, that we make this diagnosis by really doing our due diligence to rule out any other medical condition that could be explaining these symptoms. And I want to really emphasize this because this is where you are going to shine. This rarely is done in office when making a mental health diagnosis. And so having tools to look more deeply at root causes that could be contributing is going to be so meaningful for the patients who are suffering. And so here's the menu of options, choosing 5 of these symptoms to come up with a diagnosis of a major depressive episode. And we'll see that these symptoms have a lot of other reasons besides a strict depression diagnosis that could be causing symptoms like a depressed mood or fatigue or insomnia, for example. And then I want to take one moment to acknowledge that this Western medical way of thinking about depression really is just one way. When you look globally and you look throughout history, there's a lot of different ways to think about depression. So a different culture community might see it as a lapse in social fabric and connection. And so the treatment is very community based, which actually bears out in our research to see social isolation is such an important driver and something to be addressed. Just saying that we can't possibly know what our patients, the culture they come from, or what they're going through, how they walk through the world in their body, in their skin. And so the most important thing in all of this is to be listening. And this is just an overview, again, saying that there's so much when it comes to mental health that we can't even approach in clinical practice. So where they come from, what their family history is, what their attachment history is to their primary caregiver, if they had adverse childhood events, and then what they're able to do now in their life, what's their capacity to make changes, all are not quite what we can control in office. So really focusing on the right side of the screen here, which are the topics or root cause topics that we're getting into, and then focusing today specifically on neuroinflammation in this talk. This is really common. This is actually a conservative estimate of why does this matter? Again, I mentioned above all, I'm concerned about the person in your practice. That this here is saying upward almost 10%. This is again a conservative estimate. With other, we see up to 20% of adults may be affected, but here's more specifically towards maybe a major depressive episode. More vulnerable groups here, just looking at two genders, male and female. We don't have the research looking at other genders, looking at age range, etc. But all this to say is that it's not a matter of if, but when you're going to be treating this in your practice. And then adolescents, this is if you see a group of teenagers, 1 of 5 of them are going to be suffering from major depression. And then specifically in this 16 to 17-year age range, that's like 1 in 4. Okay, so let's get to treatment-resistant depression. And that's the focus of this talk. So there's not really a consensus on this definition, but typically we're thinking about the first line treatment is antidepressant medication. So having failed 2 prior antidepressant treatments that had the adequate dose and duration, usually an SSRI or SNRI class of medication. And that is significant because when someone has failed those 2 treatments, sometimes it's a matter of whether their insurance will cover the next treatment option. There's a lot of factors here, but mostly we're really wanting people to get better and having tools to do. So this is accounting for the treatment-resistant depression. 20 to 30%, maybe upwards of almost a third of patients who have major depressive disorder are not getting better from those 2 rounds of treatment. This is significant because it's 2.8 million people in the US. There's also noticing in this is just a preview to another point, that they're noticing that there's elevated inflammatory biomarkers. And that's where we're going to really focus this talk on how do we assess who is at risk for being treatment resistant, because then we know how to address these patients differently, perhaps. And so again, just with the impact here, one of the leading causes of disability, and this is from the same study that we saw the graphs earlier, looking that when someone has impairment, so this is the disability, they're not able to work, have their livelihood, sustain themselves, they're not able to have meaningful relationships, their family, kids aren't able to go to school. This is a very significant issue. And here we're looking at 5.7% of US adults had a major depressive episode with impairment, and then through 14.7 US adolescents, teenagers, are not able to live their life, live their purpose, live their meaning. That's really what gets me the most with all this. Depression is a major risk factor for substance use disorder. It can be a bit chicken and egg because sometimes people are self-medicating with substances to address their depression. And so we're seeing this, and then substance use disorder has so many other health impacts as well. I want to note that I'm going through this a little more quickly because I want to get to the other stuff and have time for questions, but this is all very fascinating in of itself as well. And then depression is a major risk factor for suicide. Major depressive disorder has a high risk suicide rate that's about 15%. And usually this is happening during a major depressive episode. And I really want to emphasize that because in this work, especially in treating neuroinflammation as a factor in the whole constellation of major depression, as a potentially lifelong issue that people are working through, that we need to reduce these episodes to save lives. So that's really what we're doing here. This is a really important. It's a heavy issue, but it's a really important issue. And if you personally don't feel comfortable managing suicidal ideation, it's really important at least to have this resource for the mental health crisis line, know your referral networks, or get additional training. And then looking at comorbidities, and this is really interesting because thinking about similar root cause biological pathways of why is depression so. Do we see when we see depression, we also see these other inflammatory conditions, where there's so much research about how inflammation drives these conditions too, right? So if we're treating just depression or treating just cardiovascular disease or diabetes, we're missing that root cause that is affecting all of them. Correlated here with dementia, autoimmune disease, and seeing that pathway being very similar. I think about it sometimes of those commercials where they have this pharmaceutical medication, which again, nothing against. I think integrative medicine, we need to use the best of best. but it has all these side effects and it's going to cause this and this and this. And when we think about treating root cause, oftentimes and it could heal this and this and this and this. So just keeping this perspective, especially when we're talking with our patients about how meaningful this work is. And then this is also a really interesting slide, and I'll emphasize that, or I'll just point out actually that this is sponsored by a pharma company, which I like to note that in these research articles we're using. But I think it's okay because it's really making the point that we need better treatment, and we need treatment that is reducing the likelihood that someone's going to have an event in the course of their major depression that is going to be impact them, lead to contribute to disability, and also be very costly. So I'll just point out here, follow-up costs for someone who has had a key clinical event that was these therapeutics that are meant for people who have treatment-resistant depression, people who have failed, let's say, 2 antidepressant rounds, go on to try some of these therapies, which have 4.3 times higher cost of their care. And these being electroconvulsive therapy, vagal nerve stimulation, the invasive vagal nerve stimulation. Dr. Habib is going to be talking about an invasive type later, which is, I'm so grateful he's here to share that with us. And then transcranial magnetic stimulation. And so just the point here is that what we're able to do, I'm really building it up, I'll get to it in a moment, which is having other tools to help reduce the likelihood that someone is going to have this recurrence of a major depressive episode in the course of their treatment-resistant depression. Okay, now we can get into the neuroinflammation part. Here's just a reminder of key neurotransmitters, the brain chemicals, serotonin, dopamine, norepinephrine, and what they do for us, what they do in our body and our mind. And we can see a lot of these line up with the criteria for major depression. So we can see appetite, mood changes, sleep issues, suicidal ideation, fatigue. So these are all things that we saw, feeling the worthlessness. We saw all these in the definition of major depression. We also saw that we need to rule out any other causes that might be causing this. And take a breath. Ready, everyone? Okay, you don't need to know all of this, but I just want to point out these are all inflammatory factors. This is what the research is showing is affecting these symptoms. So we can see, for example, one biomarker we're going to look at is CRP, C-reactive protein. We're going to be looking at the microbiome. We're going to be looking here at the kynurenine pathway just a little bit. We won't get to everything we're talking about. Please don't feel stressed about it. It would be against the purpose of this talk. But we can really see how inflammatory markers are affecting these mood symptoms. This is a really, really good article. You can take note of the PMID here. We have the references. It's really showing how well established these peripheral biomarkers that we can test in the blood are affecting symptoms. So specifically, I highlighted CRP because that's one we're going to look at. It also showed that we're seeing this also in bipolar, schizophrenia, and then here emphasizing the sources of immune dysfunction. And just as a reminder, when we think about inflammation, that is the immune system. That's the immune system doing its job. So when we think about the immune system is anything that's keeping us safe. It's our barrier with the outside world. So we have a really strong immune system on our skin, in our digestive tract, in our lungs. So these are all areas where the immune system is going to be really strong. And so anywhere where that's being affected, great in the short term, but when it's chronic is when we're seeing these elevated inflammatory factors. So infection, we'll see this in the digestive tract. And then just internally, when we feel like our barriers are not being protected, we're feeling stress. Okay, maybe another breath here. Okay, this is really cool. And I really want you to know this because this is so where the research is going in terms of neuroinflammation. We all know serotonin here, 5-HT. It is created from 5-HTP, which is made from tryptophan, which is an amino acid, a building block of protein. And typically, when we have enough tryptophan, amino acids, protein in our food, and we have the necessary cofactors like vitamins and minerals, like we're baking bread or something, we have all the ingredients, then we can move to serotonin. But when I think about it, even if we do that, if the oven isn't at the right temperature, we have all the ingredients, we're not going to be making bread. We're going to be making some like cracker or some charred thing that is like burnt. So in the presence of inflammation, of stress, the tryptophan is not becoming serotonin, it's becoming kynurenine, which then can perhaps move towards kynuric acid, which is neuroprotective, but most often is moving towards quinolinic acid, which is neurotoxic. And we'll get to that a little bit later when we're looking at the assessment. We actually can see some markers of this, of whether of is this getting to where it needs to go. And I will say that this is one indication, I'll just give you a preview, that if you're doing serotonin support in practice, you might choose for a patient who seems to have more of an inflammatory picture to choose to go down pathway a little bit to 5-HTP rather than if you were, for example, to supplement with tryptophan, just to show that why that would be.
Hey, Dr.
Now,
Waldfogel.
yes.
It looks like you can see the grayed out Zoom boxes on your screen. Do you have a way to minimize those?
Oh, gosh, thanks for telling me.
Yeah,
Like
no
this?
worries.
Oh my goodness.
I think that helps so much. That's
Thanks,
perfect.
Maddie. And this is such a good modeling of making sure that you ask for what you need. I love it. Okay, great. This is showing that functional MRI. So seeing that they're seeing images in the brain that are affecting cognition, affecting depression, that we can see the peripheral markers. Okay, so this is what it looks like. And again, this is a big image, so we're not going to go too in depth, but the main point here is chronic stress, whether it's emotional, whether it is physiological, can lead to depression at the end here. I'll go through a little bit the intermediary too. But here we see this chronic stress is affecting the tone of the hypothalamic pituitary axis, which Dr. Habib is going to talk a bit about that through the vagus nerve. It can have blood-brain barrier permeability so that these inflammatory markers can actually get into the brain, into the central nervous system. We can see the immune system in the brain doing its job and then moving towards this quinolytic acid, which we saw as neurotoxic, getting towards neurotoxicity, which then in the brain affects these key areas that affect depression. And so again, you don't need to memorize anything, just to see this is a pathway where stress, HPA axis dysregulation, can affect neurotoxicity, neuroinflammation, and depression. When we're looking specifically in the microbiome as a source of this stresses and inflammation, this is, like I said, the immune system is very strong in the digestive tract, which it needs to be because it's interacting with the outside world and we want to protect ourselves. And so we protect that barrier with short chain fatty acids here in the bottom, prebiotics, probiotics, nutrient dense food, and you have an intact barrier. When this gets disrupted for a lot of factors, stress, infection, antibiotic use, overuse, and poor diet, then these microbiota, the microbiome can infiltrate into the bloodstream. And then we have these pro-inflammatory cytokines. So this is the inflammation that can affect the stress in the body, which we saw in the last slide, the HPA axis, and create more cortisol. It can also turn tryptophan into quinolinic acid, which is neurotoxic, and affects here in the vagus nerve, which I'm going to pass it over now to Dr. Habib to share his wisdom with us.
So I think one of the really important things to look at when we're looking at this gut-brain axis, and I think that gray box may be just overlying there for a moment there, we need to talk about that microbiome gut-brain axis. When we talk about depression and we talk about neuroinflammation, one of those missing pieces is that a leaky gut becomes a leaky brain. And the control or the balance of the leakiness is actually created by the immune system. And the immune system needs to get these important signals to them. As we know, about 70% of our immune cells by volume are located in the lining of the gut. But there are immune cells that are present in every single organ of the body. These are called tissue-resident macrophages. And these tissue-resident macrophages are the target of the vagus nerve. And when the vagus nerve is signaling effectively, when we have good normal vagal tone, as we see on the left side of this image here where we have health, when there is good normal vagal tone, we're actually able to send these signals of acetylcholine to the very important macrophages that are present in the gut lining or just south of that gut lining to allow for them to stay in a regulatory state. Those immune cells are regulators of that gut epithelial barrier. When we have that good vagal tone, we can keep them in that state. But over time, as Dr. Waldfogel has brought up, stress can induce reduction in our overall function and can lead to leakiness. Stress, as it builds up and accumulates, can actually decrease and deplete our vagal tone. What that literally means is we're decreasing the signaling capacity of the vagus nerve. When we decrease signaling capacity, that means that we have less electrical signal along the length of those vagal neurons, and we have less acetylcholine then being released to the immune cells that are the target of the vagus nerve. When that acetylcholine is reduced and we're not able to get that to those immune cells, those macrophages, then what happens is these macrophages are more prone to and pushed into a more inflammatory state. And so we lack control over the immune cells. We lack the ability to control how much inflammatory cytokine these macrophages are then producing. As you can see on the right side of this image, as stress increases, it induces a depression in that vagal tone. This leads to specifically an immune mediator balance that is disrupted. We have impaired gut barrier. It's actually the job of the tissue resident macrophages in the lining of the gut to send signals to the epithelial lining to stay good and strong and not become leaky. These immune system cells send that signal. And there's some really interesting research showing that vagus nerve stimulation can help to create a less leaky gut and actually maintain that gut barrier, both preventatively and therapeutically. When we obviously lack that leakiness, or when we lack that gut barrier integrity, what happens is we have this inflammatory process coming in and we have gut inflammation, thus resulting in neuroinflammation and depression, as we can see at the top of that slide. If we can just go to the next slide there. The vast majority of signals on the vagus nerve are afferent, meaning they're coming from the body up to the brain. It actually is about 80% of the signals on vagus nerve are coming up from the body to the brain. And this includes all organs. But one of the major sources, one of the most important ones to look at, and likely the one that sends the most signals up through the vagus nerve, is the gut. And you can clearly see here just how many signals, just how many different cell types are sending signals through those vagal afferent neurons up to the brain. It's the neuropod cells sending things like glutamate. It's the enteroendocrine cells sending things like 5-HT, which is a precursor to serotonin, cholecystokinin. We've got GLP-1, something that we're now much more aware of with the introduction of GLP-1 agonist medications. Even peptide YY, these are all being sent up through vagal afferents. And then the inflammatory and anti-inflammatory cytokine activity of the immune cells that are present in the lining of the gut, they're going to be making their way up through vagal afferent neurons. There's a really interesting article that just came out about 3 months ago in Nature showing the exact pathway by which these immune inflammatory signals are sent up via the vagus nerve to the brainstem, and what that then does in the brain, the circuitry that's involved. And what secondarily has been mentioned is the signals that then go up into the midbrain, into the hypothalamus area, come from vagus nerve. In addition to the blood flow, vagal signals make their way up into the hypothalamus, and that's what disrupts or triggers the HPA axis to function in the way that it does, and to actually turn on cortisol release or turn it off. And so vagal signaling needs to be optimized. It needs to be good and strong. Vagal tone is what we're trying to create here. This is the role of the vagus nerve in controlling inflammation in the gut and controlling inflammation up into the brain. I'll pass it back to you, Dr. Waldfogel.
Thank you so much. So now let's get into the stuff that you're going to bring to the office on Monday. First of all, when I think about testing for neuroinflammation, as Dr. Habib mentioned, that if there's a leaky gut, that's leaky gut, leaky brain. So it's sort of like what is going on peripherally in the body, what's happening that is to assess that. So we're looking, I like to start here with foundational testing. So these are tests that maybe your patient even came in to you with their annual exam report, maybe starting to find a few markers you can get clues on, or to be able to run labs through insurance if that's part of your practice. Or I personally also use Rupa Health, which has really good cash prices for patients. Here we're looking at the complete blood count can give us information about immune function, certain nutrient deficiencies. We can look at the comprehensive metabolic panel, specifically fasting glucose, which we can order separately as well if we need to, especially in conjunction with fasting insulin here in cardiometabolic, just to get a sense if blood sugar regulation is affecting the inflammation. Blood sugar, of course, when blood sugar is dysregulated, that affects cortisol. That's a stressor in the body. Of course, doing your big picture, this is use your clinical judgment, the person in front of you, of what might be going on. We saw that cardiometabolic disease is a comorbidity. So if we're seeing indications there that there's some inflammatory issues through homocysteine, we'll get to, and then here, the CRP, we'll get to in a moment, then that could give us some indications as well. Inflammatory markers in particular, CRP, C-reactive protein, we mentioned is a main one used in the research studies. CRP is the same thing, but high sensitivity to find smaller amounts of it. So when we're looking to look preventatively or look at if there's any inflammation present, that might be a preferred one. And we'll look at a study in a moment. ESR sometimes is used as a marker, and I don't think if you want to throw that in, it's not terribly expensive to add, but it is not quite as specific as looking at CRP, HSCRP. Here are some micronutrients that are maybe vitamin D has already been tested, and then looking B12 and folate levels in the blood. There are other micronutrients for sure. I just wanted to do the key ones related to neuroinflammation here. And then ruling out in foundational testing other sources of inflammation that might be thyroid, autoimmune disease, looking for other autoimmune with and celiac disease as a rule out as well. And here's just to show the studies around neuroinflammation affecting 27%, which kind of looks a little bit like the number of treatment-resistant depression. Not to say it's one for one, but we see that as more severe chronic treatment-resistant depression. So here they measured CRP levels of exceeding 3 milligrams per liter as associated with some of these symptoms. If we're looking, do we use CRP or HSCRP? It's the question I get is CRP tends to be more common. I think if we're looking at someone who we're trying to get down to a lot of details, we might want to look at HSCRP. It's more sensitive. It'll give us the lower level, detect lower level of inflammation. This study from very recently, March 2024, showed that for each unit increase in HSCRP, there was 10% increase in odds of depressive symptoms. And then here are some functional testing for neuroinflammation. And again, Rupa Health is great for this, just has so much information. So I'm not going to go into depth here, but you can see some of the tests that can get deeper. So I use this either if I didn't get enough information for more of the foundational testing and foundational plan didn't work, this is to go deeper, or if someone's really suffering and want to really make sure that this is, a lot of times people come in and they needed this healed yesterday. And so really getting as much information can be helpful for people. So we're able to do stool testing, microbiome assessments to look at that gut barrier health through the organic acid test. You can look at that quinolinic acid that we saw, which is shunted from tryptophan in the presence of inflammation. So we can see that. And then looking at HPA axis through cortisol, maybe looking at antioxidants in micronutrients. And then I have this list here of other possible sources of inflammation. Again, we're detectives with our patients and trying to figure out. So this might be other paths you might take to look for where the inflammation might be. And it's always using your clinical judgment with the person who's sitting in front of you. So moving on to treating neuroinflammation. This is really what I wanted to leave you all with, to think about what can you take to the person you're thinking about right now who is in your practice or in your life to help with their suffering. It's so important. The punchline is treat the cause. We just had such an opportunity for such thorough assessment that once you know what is contributing to the neuroinflammation, then to assess that. And we're not going to go into that here, of course, but there's so many resources through Rupa Health and through other resources to learn more about that. So I split into these 3 categories: fast acting interventions, depression. I see in so many of my patients with depression, it's marked by low motivation. So it's important to have things that work quickly so that they can get into making other changes, even to be able to take a supplement regularly or anything, to have something that they can do to get them feeling better enough to make some of these other changes for the short term to be able to address, for example, microbiome dysfunction, and then overall to create lifestyle changes to prevent relapse of major depressive episodes. So, just a note, this is the conventional management. Again, using the best of all of these tools, because if someone is in the throes of major depression, we know that they're more at risk for death by suicide. They're more at risk for some really serious effects. Here are some of the conventional management of treatment-resistant depression. Ketamine is really promising in its acting nature. I'm not getting into it, but it has seen to have some anti-inflammatory effects. Neurostimulation, and so here, this is invasive vagus nerve stimulation. Dr. Habib is going to talk to us now about an invasive way to stimulate the vagus nerve. We also have some interesting interventions into psychedelics, and psychotherapy is in conjunction with any of this can be really helpful. So,
I
Dr.
think something that's really important to understand is that the vagus nerve, as we know, is the signaling mechanism of the parasympathetic nervous system, right? It's the signaling pathway that allows for us to go into a rest and digest zone. And when this signal is not working, we're going to be pushed heavily towards a sympathetic activation. And sympathetic activation is more fight or flight. A really important thing to understand is when we are unable to heal when we are in a sympathetic state. Healing is not possible under fight and flight circumstance. It requires being in a rest, digest, and I've added recover piece to this. And so in order to do that, we need to turn on the nerve that's going to signal this parasympathetic nervous system and to signal this rest, digest, and recover system. And that's where vagus nerve stimulation comes in. I'm going to talk about non-invasive vagus nerve stimulation because we don't want to do invasive work where we can avoid it, where we can do transcutaneous, which literally means through the skin, where we don't actually need to do any invasive work. There's no surgery that's required. There's no needles or any type of invasive procedure that's going to be included here. We actually have some really interesting situations that can come up. So when it comes to vagus nerve afferent signals, you'll see here, vagus nerve stimulation, transcutaneous vagus nerve stimulation is going to electrically stimulate and increase the activity of the vagus nerve through the skin. That's going to send important signals via the vagal afferents up into the central nervous system. Primarily, the first step will be to the nucleus tractus solitarius, or the nucleus of the solitary tract. This then connects to the locus coeruleus, to the raphe nuclei, and to so many different nuclei within the central nervous system, sending out acetylcholine, sending out norepinephrine, and sending out 5-HT, meaning serotonin. This is going to send out these important signals of neurotransmitters into very different areas. And one of those areas is important when it comes to regulation of optimal function. Dr. Waldfogel, if you could hit the button, you'll see one of the areas there that needs to be functionally improved upon is the thalamus. And when the thalamus is functioning effectively, this is going to support sleep, emotion, arousal, plasticity, and memory. These areas are very positive when it comes to vagus nerve stimulation. It's one of the more common things that I hear from my patients after, even for some of them, a couple days, for some of them, after a few weeks, they start to notice some really significant improvement in their sleep. And when people are sleeping better, they're getting into that parasympathetic state and recovering more quickly. And one of the flags of depression and mental health issues is dysregulated sleep pattern. So if we can help to re-regulate that sleep pattern in the short term, what we can actually do is start to get their bodies back into that regulated state. What we're then going to do is have the signals from the CNS going down into the efferent pathways, having positive peripheral effects on the gut, on the lungs, on the heart, possibly improving heart rate variability, possibly improving inflammatory function throughout the rest of the body. But in the short term, something that I found to be very beneficial is vagus nerve stimulation. If we go to the next slide there. This was a really great 5-year cumulative study that I just want to quickly touch on. I get deeper into it during the boot camp that Rupa is putting on. But what we see here is over 5 years, there was basically a group of people that were given treatment as usual for depression versus vagus nerve stimulation in addition to, so as an adjunct or add-on onto treatment as usual. And what they found was over these 60 months timeline, the vagus nerve stimulation arm showed double the number of first-time responders. It had significantly more likelihood to experience remission with vagus nerve stimulation, and vagus nerve stimulation arm had significantly more positive outcomes in response rate, time to response, and duration of response, as well as reduced mortality and suicidality. It essentially was this wonderful kickstart to push them into that recovery state more quickly. And so we were getting greater responses in this wonderful study that was a 5-year observational study. So this is a really great one for anybody who's interested in digging into the science behind vagus nerve stimulation for depression in particular. All right, and I'll hand it back to you.
Okay, thank you. So then looking at that medium term of treating the cause, right? So now that you have the motivation with vagal nerve stimulation, now we can affect if, for example, the cause we've identified as a microbiome issue. Again, sometimes it can be hard to do big dietary changes when someone is still in depressed state. And so I wanted to share some research on psychobiotics, which is probiotics that have a lot of benefit in mental health issues. And so it's really being more, there's just the research is just, we're giving you such a tip of the iceberg, but this is really where things are heading. You don't need to memorize all this, but just to show you that these are the strains that are being identified to help with neurosignaling and neuroprotection, with HPA activity, with immunomodulation, which is immune system is inflammation, right? And then this gut barrier and regulating the microbiome. Here's this big information. We'll be able to get this to you in some way, but we can see reducing CRP, reducing cortisol, all of these things for a medium term. And then thinking more lifestyle, future preventing of episodes, or I just wanted to mention some nutrients that can be anti-inflammatory, specifically for this neuroinflammation piece. There are many other nutrients that are important cofactors in the neurotransmitters, which we'll get into, as Dr. Habib mentioned, in our bootcamp course. But this is just basics around neuroinflammation, and I'll show it to you on this slide. Again, don't think about all of this, just that B6 deficiency is reducing antioxidants like glutathione, folate, and vitamin B12 deficiency is increasing homocysteine, which can lead to inflammation, magnesium deficiency, and then B2 or riboflavin, C, D, and E. So thank you. I know that was a lot. We wanted to give you some useful tools to take with you into practice, but hopefully you saw the robust research and got you excited to go nerd out on PubMed like we do, to teach your patients in plain language how inflammation in the body is affecting their mood, and then to be able to be a detective to find the sources of inflammation for them, and then have these safe, effective, and affordable options to address this with your patients. Thank you so much.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.